Okay, thank you all. Thank you all for inviting me to present today. I'll be talking about a project that actually Dr. Doyle's been helping on. He serves on the project advisory board and actually suggested I present to this group. And really, it's aimed at how do we better treat obstructive sleep apnea in Appalachia and West Virginia. Um, some of the work I'll be presenting today is actually been funded through NIH, and also have some of my time is spent on the ATS vaccine initiative, which is focused on how do we improve vaccination in patients with chronic respiratory disease. So really, the point of this talk is really just to describe our context analysis, why we thought this was really important in West Virginia, demonstrate how our team leveraged community engagement and implementation science methodologies to address this care gap we identified. And then for this talk, I'll really just be focusing on our West Virginia Sleep Apnea Academic Mentoring Partnership. And I saw in the announcements, Dr. Sharma will be actually talking to you guys about our hospital sleep medicine program next month. So just a little background on me. Before all this, I was actually working at NIOSH. I'm a fourth generation West Virginian. Stansbury Hall that used to sit on Beechhurst Avenue there was named after my great grandfather. So I've got blue and gold in my blood. But, most of my early work was done over at NIOSH, looking at really physiologic studies on coal miners and trying to understand small airways dysfunction. But I really got it when I was interim division chief here. I really started getting interested in sort of health disparities and care in West Virginia. You guys probably know all this. We're the most obese state, have bad cardiopulmonary disease rates, high smoking rates, but particularly when I'm outside West Virginia, something people really don't realize is we have some of the worst sleep health metrics in the country, which has been sort of an interesting phenomenon. You can see Appalachia here, just like every county in West Virginia. This is self-reported through the BRFS from CDC, but a lot of people, really report, short sleep duration, which has, impacts on chronic disease. And that's complicated by, other socioeconomic factors in West Virginia that make, care delivery so challenging. So this was my first sort of attempt at addressing, care delivery in West Virginia. Me and some other folks in my division worked on a telemedicine intervention to try and help patients with advanced COPD. And we really put this together on our own. And these were patients who identified in the hospital with chronic hypercapnic respiratory failure, having high CO2 elevations with evidence at baseline, and were started on NIV at discharge. The idea behind it was really to try and give them better respiratory support. The integrated approach patients really had like ongoing monitoring of their home and home ventilation. Were they using their nebulizers or inhalers correctly? And really what we ended up doing is the people that we put in our integrated approach group just got admitted to the hospital more. and I forget what the mortality rate, study was a while ago, but there was a fairly high mortality rate. These were people with advanced COPD. So I really didn't feel like we bent the needle that much as far as impacting health. And I started thinking about, chronic hypercapnic respiratory failure or bad heart failure in these patient populations. And particularly when you get to sort of advanced disease, it's almost like a cancer diagnosis as far as the mortality goes. So I started thinking about, well, what can we do to really improve health generally in the community? And we know that sort of the three pillars of health are diet, exercise, and sleep. Those are sort of the most important things. And when you think about sort of clinical care delivery, as a clinician, a lot of the programs we do, we really get involved downstream in delivering clinical care. So these diseases are already like established. We're trying to, optimize their outcome, as best we can. But when you intervene on someone's sleep or prevent them from getting in the hospital or, address these social and, ideally improving community conditions, that really has a trickle down effect on, multiple different disease processes and can really impact care more broadly. So that was kind of why we thought about going after, OSA as a potential important, um, a disease to intervene on. So our kind of first step was really identify, is there a problem with this? So we did a Medicaid database analysis looking using diagnostic codes, but just based on sort of national data, what would we expect the prevalence rate for OSA to be in our adult population? And then at least based on diagnostic codes, what was the rate? It was like 7% or something. So we were missing a kind of pretty large swath of patients. And this isn't truthfully unique to West Virginia. This is sort of a national problem. They say about 80% of people with sleep apnea are undiagnosed. So this isn't, too surprising. And then we looked out at we worked with Adam Balsa's group, and um, he looked at the EMRs in a couple of the federally qualified health centers we worked with. And as you can see in these health centers, sleep apnea at least wasn't considered or documented in the EHR very often. Presumably, a lot of these patients were not, diagnosed with OSA. So we thought, well, great. How do we sort of get care out to these communities? And, there had been a lot of work showing that primary care can, manage patients with obstructive sleep apnea. Now, I will say a problem with a lot of these studies is a lot of people with the chronic health conditions we see, like heart failure, COPD, comorbid with the OSA, were not included in these studies. So you had to have like straightforward obstructive sleep apnea. They were also like highly motivated people who kind of went out of their way to get involved with this program. So they were really interested in sleep, the primary care people in sleep apnea care. And went through pretty extensive training, as part of these studies. But treating these patients, particularly the high risk ones in West Virginia, I mean, it certainly can have important impacts on their um, clinical trajectory. This was a study Dr. Sharma did in Philadelphia, where they looked at patients who are admitted for COPD, and you can see if you had a diagnosis of sleep disordered breathing or sleep apnea, your risk of readmission was double that of people who didn't. As your severity went up, your risk of readmission went up. And you can see in the severe group, it was 70%, which is pretty astounding. And this was a study done at Ohio State, just looking at patients who actually had the diagnosis of sleep apnea made in the hospital and were discharged on CPAP therapy. You can see, like, if you got your diagnosis of sleep apnea and you were adherent with your CPAP therapy, there was no readmissions over 30 days versus either partial users or people who did not use their machine. So certainly may impact uh, outcomes in our patient population. This was a study done at the University of Washington, and it was actually a sleep medicine echo, kind of like the chronic lung disease echo we're doing right here. And there was a lot of excitement around that. People thought that sleep apnea, insomnia were really like prime diseases to, potentially, replicate what had been done with hepatitis in this group. And so I remember I actually moderated a session on this, and these are really, really well attended sessions through the VA. But they looked kind of 5 years out from it. You know, there was really no sustainment in like sort of doing the diagnostic or evaluating treatment of OSA from these primary care providers. And what the authors of this follow-up paper concluded is that although there were knowledge gains, it really didn't translate into increased self-efficacy in sleep disorder management. And the feeling was that, the primary care people felt that patient education, management of insomnia was really within their scope of practice, but they did not have that perception about sleep apnea, uh, at least based on this 5-year follow-up data. So, as part of our work, we drove around West Virginia and went to some different places and talked to primary care about, what were their thoughts on obstructive sleep apnea. We also gave them the OSA Knowledge Questionnaire, which is a validated questionnaire to assess sleep apnea, baseline knowledge. And as you can see, like people scored really well on this. I mean, there were just a couple questions that were kind of almost universally missed, but in general, the knowledge was really good. And people, at least who talked to me, felt that that sleep apnea was a very important disorder to sort of consider and diagnose, but really didn't have much confidence in identifying or managing sleep apnea. This is just me at one of the meetings. Dr. Doyle was at this one at the Domino's Pizza meeting outside. And so essentially what we did is we sort of got people's feedback on what they think about sleep apnea, what are barriers to care, kind of throughout West Virginia. And we use this information to develop a program to hopefully address sleep apnea. And we use the VA query model to really come up with a plan on how we're going to do this. And I think one reason our telemedicine COPD intervention failed is me and the team knew what needed to be done for these patients who were coming from these rural communities. And I think that demonstrated we know nothing about taking care of those patients. You guys are really the experts on that. So it was really important to me as we were getting this going to make sure, those voices are considered and we had like a framework, step-by-step understanding on how we were going to do this. So the Consolidated Framework for Implementation Research is a implementation science framework that lets you kind of construct barriers and facilitators and map them to different domains. And it's really a way to help you think of what are the different steps, characteristics, things that need to be done to effectively deliver care. And what are facilitators we can potentially leverage to make this happen in West Virginia. And we used this CFR analysis we completed with an online tool called the CFR ERIC matching tool. And ERIC is just the expert recommendation on implementing change. There are 73 different strategies that have at least some data showing that they can impact care change in a healthcare system. And so kind of what these were ones that kind of rose to the top for us. I think the ones that were kind of most helpful was developing the partnerships with the PBRN and West Virginia Rural Health Association, as well as having our advisory board, which I think has been a real key to kind of consider what we're doing in the program. And then, providing support to our primary care providers, as that previous research has shown, and as well as our, analysis suggested, there's just not a lot of confidence in providers on sort of managing obstructive sleep apnea. So being able to provide that support, our thinking was, that might really make this come more to the surface and front of mind for people to consider this in our patients. So this is actually our home website. And this is what our sort of program looks like. Any of you guys interested? I think this is from last year, but I think our next training date's April 27th. It might be at the end of this, but make sure I let you guys know so we can sort of spread the word. But this is what the training session looks like. This is a half-day training session. Kind of the topics we cover, and it's really based on feedback we've we received in the work I've shared with you. We've actually modified this a bit based on feedback from people who've gone through the program. But these are the things we discuss kind of during the day. It's done over Zoom. This is what it looks like. So this is sort of the Zoom presentation. And then, we have our speakers and, we're sharing, PowerPoint slides. We have slides in there to try and facilitate discussion. And there's also a lot of good discussion that happens in the chat while we're going through this. And actually, the first one I did, I kind of forgot to even look in the chat, and there was a lot of great discussion that I completely missed. And thankfully, someone told me that that was the case. I kind of felt bad after that session that I missed all that. But so a lot of good teaching and discussion that occurs. This is the clinical workflow of the AMP program. So I don't know if any of you guys have done any work with Judith Feinberg and the hepatitis C group, but it's really modeled after what she does in REDCap as far as, entering patient information, asking questions, and then a feedback loop where, that question goes to the faculty. We give our recommendations and they either, act on that, or if there's still more questions, they can, route it back to the faculty for sort of more discussion and, do management that way. This is what our REDCap database looks like and sort of what gets entered. Try and keep it as simple as possible for individuals. One thing people didn't like was entering all the testing data manually into here. So we did add an option based on feedback where you can just drag, if you get your sleep study back that you've ordered on a patient, you can actually just drag it back, drag it to upload the file here. So looks like Dan mentioned there's sites that use REDCap for black lung monitoring and recently for pulmonary rehab clinical outcome measures. So yeah, it's a good resource. And then this is what our recommendations and treatments after we review this data and we recommend our treatment, we usually click one of these, and then we'll a lot of times put a comment in if necessary, like what to consider, things of that nature. And then this is our follow-up, so if they've gone on APAP, what does their data look like? And again, we added an upload file here in case they get a download that they just want to upload to REDCap, or what if they've done one of these other treatments, how's it going? As part of this training, we've had 46 providers go through the training in the first 18 months. So pretty good number. And this is just an example of some of the questions we ask post-training. And these are based on the acceptability and feasibility intervention measure domains. So these are validated domains that let us know, hey, we feel this is acceptable to introduce in our practice. We think this is feasible to introduce in our practice. We presented this last year actually at the sleep meeting. So we only had 18 participants at that time. So we've analyzed, I think, like I said, I think we have 46 participants now. And I think, 20 some have completed the, post-training questionnaire, and we're still getting, this is, on a Likert scale. So we're still getting very high ratings of acceptability and the feasibility from this, initial feedback we get. So, like I said, we've trained 46 providers across, and it's across 20 counties in West Virginia. As you can see, mostly in the southern part of the state, but there's some to the east. No one up north yet, but that's not necessarily surprising, as we have a fairly big sleep center at WVU, and then Wheeling has a very big one too. So I think the access to care there is probably less of an issue. We have 17 providers who have actively enrolled in the REDCap consult system, and then we have 19 who've actually put in consults. So What have we learned in our first 18 months? Well, I think, a lot of the feedback we get is make the training days interactive as possible. The first couple of sessions, we kind of got feedback that, hey, you're just like teaching at us. There's no discussion. So we, modified our presentations. We've actually put in breaks where now we ask the participants questions and try and get some discussion that way. Our first set of slides, first time we did this, we got some feedback that they were got into the weeds a little bit more. And, looking back, I agree. It probably wasn't some of the stuff we were going on over was probably not absolutely necessary to understand to effectively manage sleep apnea. So we modified the slides a little bit. Getting red cap access has been a little bit of still an issue. It's getting better, but if you're at a site that has not done like one of the AMP programs or anything like that, your health system has to get a data use business agreement with Adam Balsa's group. It's not a huge deal, but it takes 2 to 3 weeks, and then 2 to 3 weeks or a month pass, and you're like, oh, what was I supposed to do with all this? And it's not top of mind anymore. So that's been an issue. One like feedback point I've gotten, I've brought up to some of our members that, based on our data, I would think we'd get a lot more consults than we have. And they still say, yeah, we think this is a really important topic, but it's just not, top of mind when I'm busy in clinic, trying to do 100 different things. And, it just doesn't remain top of mind. But the patients who have gotten their care really appreciate doing it in their own communities. Medicaid was kind of a barrier to OSA, or there's some better options now as far as testing goes that are just starting this year. So hopefully that's a less of a barrier. And then a couple of the consults we've gotten actually were for people who are already on treatment and actually like needed a new device or needed troubleshooting of their device that they've been on for a while, which I kind of didn't expect. So I think what we're, really trying to focus on now, I feel pretty good about where the training program is and how the teaching goes, how people feel about it. I think we really need to like talk about after after providers complete this training, how do we really like work on that sustainment, like keep this top of mind in clinic, which has really been a struggle. We have sort of developed these welcome packets that we send out to everyone who's completed the training. I kind of send an email newsletter around every month just to give sort of updates on OSA care and, to ask people for questions, thank people for their for the care of their patients. But I still feel like something's missing there that we need to address. And, I think my plans for the coming spring and summer is just driving around to meet with folks who've done our training and just see like what can we do to better support them and keep this top of mind in clinic. And the other thing that I think we really need to focus on is the patient engagement. So much of the work we've done now has focused on the providers. So I think the next piece of the puzzle is really understanding the patients who, particularly from the communities that where we have these providers, what do the patients think? That there's some data that suggests that like doctors don't do a good job asking about sleep complaints, and then patients don't do a very good job of like volunteering, hey, I have a problem with my sleep. So maybe it's something like just a sign in clinic or something like that. But working on that sort of over the next year. And this is the important groups we work with to, deliver this. And the West Virginia Rural Health Associations, does a lot of support for us, does the Zoom meetings, does the CME credits, does that sort of work. And then Adam Bouse's group manages our RedCap database. And then Dr. Sharma and Dr. Rojas are some of our faculty presenters. And then you guys all know this handsome guy, Dr. Doyle, and then some of the other people in our project advisory board. Really diverse, multi-interest stakeholders. Jen Lucas unfortunately left. She was the dynamo with the PBRN, but we have Miss Abel with us now, who's doing a really good job and actually working with me to kind of set up some of these visits across the state to sort of address sleep apnea. And then kind of people who mentored me and has really helped me do the program evaluations, put this program together. A lot of my work's based on the awesome work Dr. Feinberg's done. So that's kind of where we are with everything. And I think I will stop there.